of these between the cone and between the oxygenator ports for almost everything. I think the only thing that I give on the arterial side is platelets, because even our aminocaproic acid we put on the front side, right? Which I have mixed feelings about, but,
So that they give boluses of drugs almost universally between the pump and the oxygen.
correct.
And I'll give almost nothing before the pump.
Correct. The only thing that's before the pump, even though the stopcock is this here, the only thing they're really doing is transducing this pressure.
Okay, that's why I was at, because like you said, there's so many,
Yep.
I just wanted to make sure that there's a standard place
Yep.
where it.
And they also get drilled on this whole negative and positive pressure and acting as a filter so that they're really aggressively thinking about it. But it's an excellent question.
And all of the drips as well typically get hooked up between the pump and the oxygenator.
It's basically, it gets hooked up between the pump and the oxygenator unless there's a reason to give it somewhere else. So because there was this thought process that the oxygenator sucked up the platelets, that's why it's given on the backside. So it's known as an exception. Everything else is just assumed that it's being given pre-oxygenator post-pump. Makes sense? So the things to keep in mind are that PRBC, saline, 5% albumin, we don't feel like those things do anything bad, or FFP do anything bad to the circuit. So when you have your exsanguinating patient on ECMO, again, if you ever have a choice of an exsanguinating patient, have them on ECMO because you'll never have better sources to push blood through, and you can see how many connectors you have. So it's astonishing how many people you can actually have putting product into the patient trying to overcome the exsanguination. Oh, I know, there's one other thing I was gonna say about the. So I keep referencing that we have different size circuits. So partly the different size circuit is based on the oxygenator, and so how fast you can run your sweep speed through the oxygenator, and how fast the blood flow can go through it, because that's what dictates the maximum amount of ventilation and the maximum amount of oxygenation that you'll get from it. The other thing that changes when we change the size of the circuit, I told you the pump head stays the same. The other thing that changes is the size of the tubing. And so this, what you see here is what we call our big tubing. This is 3/8" tubing. So we have 1/4" tubing that we use in the neonatal circuit. So why do we do that? We do it to minimize the amount of blood within the circuit. So we talked about how this holds about 400 cc's, and the neonatal circuit holds about 250 cc's. So it makes a tremendous difference when you're thinking about connecting your patient to the circuit.
Do you have like weights that you, do you universally put everyone with a blood primed circuit, or do you say a lean primed sub?
Everybody's blood prime. We'll talk about the priming formula in the simulation talk, but everybody gets blood primed, which is important to start thinking about when you start thinking about CVVH outside of here. It's amazing how many of the principles of ECMO also apply to CVVH when you're using it in your other patients. And for example, we had a patient in the cardiac ICU for the last 2 weeks who had profound heart failure, who we failed going on CVVH 3 times because of her not being able to tolerate it from a hemodynamic standpoint and clotting off her CVVH circuit while we were doing it. And we finally got her on the 4th time, and then I did one of her circuit changes with her, and I knew when to change the circuit because of principles that I know from ECMO, and I also got her through smoother in going on ECMO, on CVVH than I think most other people were able to do, because I understood all of the electrolyte and other things that happen with ECMO when you connect someone to plastic and blood that's not meant to be exposed to your body.
I don't see it, but I just wanted to ask out loud, because bypass has it and roller pump has it. This does not have a venous reservoir, correct?
Correct. It has. There's one thing that it has. There's no reservoir. So what a reservoir is that Alex is asking about is that if you generate really negative pressures, then one of the things that can happen is that you can start sucking air into your circuit. And 2 things happen. You can either directly suck air into your circuit because of loose connectors, or you can start to, I just lost the word that I want. What do you call it when you coalesce the small oxygen bubbles into bigger oxygen bubbles? I'm looking at spallation right now, and it's not that. I can't believe I just But you can generate such negative pressures that all of the air that is microembolized within the blood actually starts to coalesce together, and so then you can have air emboli that develop in that way. So when you have roller pump circuits, what you have somewhere pre-pumped is that you will have a reservoir with blood in it and air sitting on the top, so that you have a constant source of blood that you can draw from in case you start becoming so negative you can't draw from your patient anymore, and then you start to empty that reservoir to minimize the risk of developing an air embolus in that way. There's another way that you can modulate that we'll get to in a second.
I'm assuming this one, when your pressures get too negative, it just like slows the RPMs.
Yeah, or
like,
shuts it down.
It forces you to, and eventually would just turn the pump off if you had like a clot in the venous.
Correct. Correct. Okay. Excellent, you guys have such good questions, we don't even have to look at all those slides. Okay, so another component of the circuit is this thing called the bridge. So this circuit is all fine and good, right? It's connected to the patient's running on ECMO, everything is happy. Now the question is either what if something goes wrong, or what if you want to see how your patient is doing when they're not on ECMO any longer? And you have to have a way to circulate your ECMO pump, because if we shut this off, what's gonna happen?
Thrombose.
The whole thing's gonna thrombose, and if you wanna go back on, it's not gonna work. And so there's this thing called the bridge. So this is, so venous limb, you can see the blue, arterial limb, it's hard to see the red. And the first thing that you find when you leave the cannulas and start walking down the circuit is the stopcock in place when you're going through the venous limb, and then you can see that it shoots over to the arterial limb. So this is the bridge that everybody talks about. So what this is for is if you're having problems and you have to clamp off from your patient, or if you want to clamp out to trial a patient off ECMO, what they'll do is they'll clamp the tubing somewhere up here between the cannulas and that bridge, so there's no flow through there, and then open up the stopcocks through here so that you have continuous flow through here. So there's a couple of reasons why this is important to remember. Number one is if you're the one that's on call at 2 o'clock in the morning, because that's when everything always happens, and they call you and they tell you that the ECMO circuit stopped working, the first response when you lose flows on ECMO is supposed to be to clamp the patient off from ECMO. And there's two reasons for that. One is it's just a safety feature, so something doesn't all of a sudden happen to the patient, and you clamp them off, and then the bedside nurse can go to thinking about just managing their patient without ECMO on. The other reason is as soon as you clamp off, you open up this bridge. What's the first question you're gonna ask when you walk in the room and they say that they didn't have any flow and they clamped off? Is the bridge flowing, right? Because if the bridge is flowing, what do you know?
Probably not the
Circuit's not
circuit's
flowing.
problem, it's
Right.
probably the patient's
So
problem.
everything from here through is fine. So this is all good. Your pump works, your oxygenator hasn't clotted off, everything is fine. And these are the two that can clot on you without you being able to visibly see it. I can say I've never had tubing clot off and stop a circuit. Bladder, yes, but just straight up tubing. Have either of you ever had a circuit or heard about a circuit going down? Because you can see the thrombus that's developing in here, and there's so much flow through here that it doesn't clot off there. But these two can clot without you seeing it. So when you clamp and you have no flow through here, then you have to think about whether one of these two things are clotted, and it's gonna be your pump head unless you know your transmembrane gradient has been climbing up here. You don't go from a transmembrane gradient of 10 to the thing clotting off in 5 seconds. If that happens, then it's really your pump head that just died on you. But if you don't have, but if you have flow here, then the problem is either pre this, so something to do with your venous cannula, or post-bridge, something to do with your arterial cannula. Because again, this tubing is pretty decent size and you can see it, and so then you don't have clot that's developed in here. It's always hidden within the cannula or the patient themselves.
With roller heads, there was a very specific way that you needed to clamp them and
Yeah,
unclamp them.
people
with
still do
centrifugal.
VAV, but it doesn't matter as much. It just makes the circuit alarm, and you'll have some minor changes in your patient's preload and afterload, but we still talk about it a little bit. What was I gonna say? Forgot. That's good. All right, so that's the bridge.
bridge, the diameter of the tubing is a lot smaller. Can you keep the same flow rate through that?
Oh, that's what I was gonna say, thank you very much. That was exactly what I was gonna say, is you can see that that bridge is very small. And so what you will see is that you won't flow as well through this, right, because this is so small. So when you open up your bridge and you start flowing, do not be surprised that the flows are much lower. And that doesn't imply that there's a problem on this side. All it implies is that you're flowing through this higher resistance bridge. So the ECMO specialists are trained to bring their RPMs down close to 1,000 when they flow through their bridge, so that they're not trying to force all this high flow through this small resistance area and having hemolysis occur. If that happens, without you guys being aware of it, but my hands are a little cold. It's so cold. That's to keep you all awake if you fall asleep. All right. I think we actually did much of the circuit monitoring stuff already. So that is the circuit. Did I miss anything in the circuit before I go into monitoring that you can think of? Okay, so for circuit monitoring, we keep talking about hemolysis, and this is partly why we do this monitoring, is because of hemolysis. So what you have here in this slide is time, and then you can see up the y-axis there's this thing called plasma-free hemoglobin. So plasma-free hemoglobin is what it sounds like. So it's just hemoglobin that's floating around in your bloodstream, not contained within a red blood cell. So this is what happens when you break down red blood cells. Every morning on ECMO, there's a plasma-free hemoglobin sent to the lab. The lab batch runs them at about 9:30 in the morning, which is helpful if you round on your patient after 9:30 in the morning. If you round on them before that, it's easy to forget that this number is being obtained, but you should be aware of it. And it's also easy to forget about because currently Saturdays and Sundays, our lab doesn't run plasma-free hemoglobin, so you really only have it Monday through Friday. So the reason why plasma-free hemoglobin is important is because it tells you about the health of your circuit and then the hemolysis factor. So for us here, we expect to see plasma-free hemoglobins less than 75. If it's greater than 75 in the ECMO manual's guidelines for changing your circuit, that's one of the things to prompt you to start changing your circuit. Now, the hemolysis isn't just because of turbulence within the circuit itself. So if you're getting clot within your pump head and you're having higher RPMs, you'll have higher, in order to generate the same flows, you'll have more hemolysis. If you have lots of clot within those connectors, you'll have hemolysis. But we also think that it has to do with the viscosity of the circuit, and meaning how high your hematocrit is. So if you look at the units and compare the units, the CTICU compared to the NICU in particular, because it's the same size kids, the NICU runs a higher hematocrit. They're just like, don't look at me. Then the CTICU tends to use, although you guys are changing. Change happens. And so we tend to see higher plasma-free hemoglobins in the NICU than we do in the CTICU. So I say that because for you guys that work in the NICU, when I say if it's greater than 75, we really start paying attention to it. You're going to tell me, but the plasma-free hemoglobin is always greater than 75, and you guys worry more when it gets into the hundreds. The reason why it's important is, one, it tells you how your circuit is changing over time, and two, and more importantly for me, is that plasma-free hemoglobin clogs the tubules in the kidneys, and so it can induce acute kidney injury in and of itself. And so part of the reason to try and keep the plasma-free hemoglobin low is to try and maintain the health of the patient's kidneys. So what this shows you is this is actually the red dots are when the circuit was changed. And so in this patient, you can see their plasma-free hemoglobin got up to 350. We changed the circuit, and then the plasma-free hemoglobin drops down low and rises low for a while, and then all of a sudden it spiked again, and then the circuit was changed again, and then they dropped down. So changing the circuit really can make a big difference for how you're doing with this. So pressure monitoring we talked about the venous limb. We talked about, so why do we care about venous pressure? Oh, so I talked about what we were measuring. or where we are measuring it, here's why you care. So if the centrifugal pump is more sensitive to changes in preload and it doesn't generate as negative a pressure, that means you have a threshold at which it's gonna stop functioning. That's partly what Alex was asking. So in patients on centrifugal are smaller babies, and again, this is where, I don't expect you to memorize in the moment, the more you hear this when you're listening to patients, think about these numbers. So when I have a neonate on ECMO, the venous pressure that I'm anticipating hearing is at best, it could be 0 or just slightly positive to net negative 10 or thereabouts. That's the best range that you're ever gonna have. When venous pressures start getting down closer to negative 50, that's when you start worrying about how well your centrifugal circuit is actually gonna keep running, and then it'll shut down on you. Where's the absolute shutdown? What's the limit?
It's like 99, minus 99, negative, I don't even think we can set it to negative 100.
Yeah, that's
So
what
it's
I
like
think.
negative 99.
Right, so you can get down close to minus 100 on a centrifugal pump before it shuts down, but it doesn't usually like functioning down at that low of a range. But it's really dependent on how much flow you have going, right? So the reason why I'm saying neonates will be close to 0 is because they don't have that much flow going through their circuit. We usually flow somewhere around 100 to 150 mils per kilo per minute on patients. So then that means you're looking at flows of 250 to 400 in our neonates, as opposed to adults, which you've already heard me talking about flowing at 5 liters per minute. And yes, they have bigger cannulas, and yes, they have a bigger circuit, but they're not exponentially bigger, and so they end up having lower negative pressures. So it's very common in the PICU that when we have adult patients on, or in the CTSU when we have adult patients on, you're gonna see the negative pressures down closer to minus 50, and that's just what it is. And then you can see what you can do to change it, but usually that's where it rides. And that's an important one to remember, because since we do so many of our patients here are neonates, we get so used to seeing it at minus 5s that when they're running minus 45, everybody panics. We talked about hemolysis and beat that into the ground. So troubleshooting, so this is again where knowing things like where you're monitoring makes a difference for you, because if we say that on a venous limb, you're transducing this pressure here, the low negative pressures is everything prior to this. So what is everything prior to this? So all of a sudden you have a negative pressure that's much lower than you were expecting it being. What's causing it?
Hypertension, tension pneumothoraks,
What was the first one you said?
hypertension, or I guess hypertension, so low volume, intravascular volume.
Right, and more hypovolemia, not pressure, that's why I wanted you to turn it around, because if you're on PA ECMO, then you're generating a cardiac output from here, so your patient may or may not be hypotensive. If they're hypotensive, it may actually be because you have decreased flows. So the volume of your patient, and then you're right, tension pneumo, so this is where knowing where your cannula is, because if your cannula is sitting in the thoracic space, if you all of a sudden have increased thoracic pressures, and it's going to be hard. It's just like when you get a tension pneumo or when you get a pericardial tamponade, you can't get volume into the heart. So that means if you can't get volume in, you can't get volume into your circuit. So it acts as relative hypovolemia for your patient. Okay, what else? What else do you think would make it harder to look into the circuit?
Poor positions, venous catheter.
Right. And so, and I like the way that you're thinking, because the way that he's thinking is he's starting before it even gets to the ECMO circuit, and then what's the first point of the ECMO circuit? The first point of the ECMO circuit is your venous cannula. And this is where it makes a difference about whether, is this a patient that's been on ECMO, or is this a patient that you're first cannulating to ECMO? If it's a patient that's been on ECMO, if they haven't been moving the patient, hopefully the cannula position hasn't been moving, and your cannula size definitely isn't changing without you being aware of it. So you go more quickly to hypovolemia and changes within the pleural pressures of your patient. But if you're doing a cannulation and you're hearing these negative pressures, you're thinking about, okay, what size cannula did they put in again? And oh yeah, does it sound like something I normally hear? Or did they say that they were going to give me a 14 French venous cannula, but while I was standing here watching the cannulation, all of a sudden I heard him saying, hey, can you pass me the 12? Hey, can you pass me the 10? Because they couldn't actually get a bigger cannula in. So then maybe your problem is that you've got a relatively small cannula. or it's also really dependent upon the positioning. And so as they're positioning it during the surgery, do you get better flows if they tweak it this way or better flows if they tweak it that way? Make sense? And then after that, so then you've got your cannula and then you have an adapter and all this tubing into the pressure line. And again, you rarely get big clots in there. So it's really more about what you can't see in your patient and the venous cannula itself. As opposed to if we come to this oxygenator pressure monitoring, what's that telling you about? So this is a negative pressure, right? Because this was on this side. Now we're going to the postcone side. This pressure is going to be. So it's what's downstream from it. So the membrane is downstream from it, but what's also downstream from it is what you're measuring with your post-membrane oxygenator. And so your post-membrane pressure is transducing everything off the back side of the oxygenator to your patient, right? So now, if your pre and your post-membrane pressure have the same gradient across it, where's the problem? Patient side. If the pre is high and the post hasn't changed, or the post has actually dropped because of less flow going through this, then your problem is within your oxygenator yourself. So if your post-membrane pressure is high, where's the problem?
Is it hypertension?
Not necessarily hypertension, because pressure is what?
Resistance is low.
Hmm?
Flow times resistance.
Right, and so if you lose flow because you have high resistance, because your centrifugal pump can only generate so much positive pressure. So if your resistance goes up, your flow goes down, and you may not actually have hypertension. It depends. So the way to think about it is resistance. But before you even get out to resistance in your patient, what do you have? Well, first you have tubing that you can see, so you'll be able to glance and see whether you've got a clot in there, whether they don't have the bridge stopcock turn all the way open. But really the first thing that you get to is your arterial cannula. And again, with your arterial cannula, if this is a patient that you've already had cannulated, are you or are you not worried about thrombus developing within that cannula? And that's the only thing that's going to change the size of your arterial cannula for you. Could you have shifted position because they decided that now is the opportune time to lift the patient at 2 o'clock in the morning and change the mattress that they're on and put the patient back down? Or are you dealing with things on the far side of the cannula, which really is all about your patient's SVR? All right, pressures. Guidelines for titration of pumpkins, we just try and keep the RPMs as low as possible. Oh, this is one of the things I was going to say, you guys. So when we talk about having made the transition from a roller pump system to a centrifugal pump system, and I talk about how the roller pump generates low negative pressures and high positive pressures, that means for a given RPM, you're going to maintain the same flow for a broader range of pressures, right? And so then if your patient gets a little preload dependent and you're set at 1500 RPMs and you're flowing at 1 liter per minute, your patient gets hypovolemic, your circuit's going to still keep running and still keep running and still keep running. So one of the things that you can tell from this program that we came from roller and that we haven't fully migrated over to centrifugal is that you'll still hear the ECMO specialist talk a lot about the RPMs more so than about the flows. And so you'll walk up to the bedside and you'll say, how am I doing? And they're like, great, I'm on 1400 RPMs. Well, I don't really care how many RPMs you're on. What I care about is if I want my patient flowing a liter, is that patient flowing a liter? Or you're on 1400 RPMs and now we're only flowing 500. And so that is one place where we're still working to make the transition. I think it's getting better. I think in the last year in particular, it's really started changing, but that's one thing for you guys to remember. So you want to get the flows and you need to know what kind of RPMs it's taking to generate that, but the ECMO specialist can titrate the RPMs as much as they want to in order to maintain the flows, because what you're really supposed to be ordering is the flows of the patient. The other monitoring that we do, and this is also my old slide, is sat crit monitoring. And so we measure saturation and hematocrit continuously within the circuit. So M3 has many more things on it. It measures your sat and your crit from up here in M3. so on the venous limb, you have a blue SpO2 here, and so that is what this one is. So it's the one thing that'll be clamped around the tubing, and these are size dependent. So for example, this is the 1/4" sac probe, and that's why we don't have it on here. The one that fits the 3" circuit looks exactly the same, it's just a bigger diameter. So when you're coming and walking along the circuit, you'll run across this flow probe that you'll recognize, and it says flow and it has an arrow. You'll also run across this thing that looks a little bit different. And if you follow this cable up, where does this cable go? This cable goes here. If it's on the venous limb, then I look up here, and when I look up there, I'm like, well, it's not my flow probe. Oh, that's right, it's my SAP probe that's up here. So it'll continuously measure your SpO2. But again, this is where understanding how you're cannulating, what's happening with your patient is a big deal. Because if this is a patient who has a cannula that's sitting in their SVC or in their right atrium, then this is a pretty good mixed venous SAP for you for that patient, right? But if this is a patient who's in the cardiac ICU and has LV failure, sometimes we'll put a cannula into the left atrium as well to fully decompress the heart, and so then that gets wired into the venous limb of the circuit. And if we're lying in blood from the left atrium, what's delivering blood to the left atrium? What blood is in the left atrium? Pulmonary venous blood. So if you have even a small amount of 100%, that's going to contaminate what's in your venous limb, and so this is no longer truly a mixed venous. Make sense? So this can be helpful though in terms of now when you're, again, doing something for your patient, so you're flowing them on ECMO and you want to see what you're doing for them. So if you have a patient who's on for cardiac reasons and you say, well, I think that for the cardiac output, I want to flow at 125 mils per kilo per minute. So then you put them on that. How are you going to know whether that's enough for your patient?
Give me SpO2,
Right.
so look at tissue perfusion and.
Right. Right, so the same that you do for any patient, anytime, anywhere, if you're worried about their perfusion, the first thing you do is you look at their blood pressure. So on centrifugal, this is continuous flow, so you don't get a systolic and a diastolic pressure. If your patient is beating on top of it, you may, but we tend to just follow the mean arterial pressures when patients are in ECMO. So you're monitoring their pressure, and then what else do you care about? You care about whether that pressure is really doing what you expect it to do. So what does your end organ perfusion look like? So how are your kidneys functioning? What's your lactate doing? And then what's your mixed venous sac coming back? And so we set a threshold here standardly of saying that we want our mixed venous sac greater than 70%, so that you have some kind of idea of knowing about if it's less than 70 people coming and talking to you and saying, hey, it's not 70, are you worried about our cardiac output or our oxygen delivery for this patient?
Is there a kind of standard that, again, like when you're born, that they, according to age or size, that they flow?
We choose
Like a
flows.
100, yeah, I mean, like, is there,
We choose the flows. So
Okay.
they is us. and-
yeah, that's what I mean,
Yeah.
like, but is there, it seems there's so much protocols, I'm just trying to learn.
Yeah.
Like, for different sizes, do you guys typically start a certain flow, like 100 for a smaller child or a
We'll
70
get to
for?
that. I can't remember if it's in your medical management talk or in my medical management talk. Or if it's, no, it's in my VA talk. It'll be this afternoon. We'll talk about the usual flows. Okay, so that's the SAT on the venous side. The other thing that this thing gives you is if you look over here on the end of this, and this is the only time you'll ever hear me talk about the last 3 boxes. On either arm of this tells you about the number of emboli you have flying through your circuit. And so this will tell you your venous emboli, and it's the volume, it's the absolute count, and then there's a total ever for the life of this circuit. I fully disregard those numbers, because if it tells me there are 1,052,000 emboli flying through my circuit, and my circuit is functioning fine, I'm not gonna respond to that number. If it tells me there's 1 emboli flying through there, and then my circuit stops, then I kind of care about that single emboli. So measuring them is completely irrelevant to me, and I don't know anybody that actually uses those emboli counters for any reason, but they're technically up there. So then if we measure venous SAT, then we also measure arterial SAT.
The black box.
So this one is bigger and clumpier, so again, you'll be coming along, you'll come to your arterial limb, you'll see a flow probe that looks like a flow probe, and then you'll see this big box on it that is clipped here. And nicely, it's labeled System M, so you know that it's up here as well as following the cable to up there. And then it one violation, so this is all venous, is your hematocrit is technically measured off the arterial meter circuit, but it doesn't matter. And then it gives you your arterial saturation, which frankly I don't ever use for anything, because I was usually patient saturation, that's what I care about more. And then I know what my post-membrane gas. Have you ever used has the post-oxygenator sat ever
It's always
solved
100.
anything
No.
for you guys? Yeah, because we always run our pH greater than 250. And then it also tells you about arterial emboli, and I for sure ignore those, because those are the ones that are going straight to my patient, and I don't wanna know that I have 1,052.
For fun, I just like to set it at the beginning of my shift to see how many went through in my 12 hours.
How accurate is the continuous hematocrit reading?
It's quite accurate. It was, we do Q6-hour CBCs, and they verify it at that point in time, but it's really nice, especially in
You said the next games you put in right before the oxygenator?
It's before the pump.
That was before the pump, not that it should be.
And then we talked about all of it is the mirrors.
You can let them set for just a second so that,
They can, actually, this is the one talk that I was realizing it's good for you to practice, and I know you're following me with the camera, but this is the kind of thing that people can't watch on video, we'll have to walk them through it. There was one more thing on here I was just gonna tell you guys about.
Do you have a bubble,
Yes.
bubble detector?
Yes, that was what I was just gonna tell you about. That was also in the slides that I put in, that had disappeared.
it's just not, it's that right there. It's not hooked up.
Well, I'm trying to move it so they can see it. So this is the bubble detector, but there's no way through. And people mostly see this from where I have it. So what I'll tell you is that the bubble detector, typically, is this gonna alarm if I put this in here?
No, it's turned off.
So typically, this would be sitting here. and be able to-
Is that the 3/8 side?
Yes.
It's still hard.
No. Oh, I can't make it work right now. Alright, this tubing is supposed to be in here, and I'm just doing this so you guys see where it lives, because I want you to think about where that would be. Okay, so this is what's called the bubble detector, and it's on the arterial limb of the circuit. So what's your best guess? And then, actually what I'll tell you too is, if you follow these cables, where are these cables going? To what?
You call it the brain?
To the brain, to the sorin, right? They're disappearing into the system. So there's something on the arterial limb that's called a bubble detector and runs to the brain of the system. What do you think this is? That's an off switch, that's right, and that's a super important thing to remember. So as much as I tell you that the SAT monitors measure emboli, these measure tiny, small emboli, and so you see 1,052 of them. But if you have a really big embolus going through here on the arterial side, do you want this going to your patient? Ideally not. And so what this does is this detects emboli that are flying past of a bigger caliber, and I don't know what the difference is. Do you know either of you remember the difference? Exact size.
I don't know the
How many
exact size.
microns it is, but, so if it senses something going through, it goes back and it feeds back to the sorin and it drops the RPM or shuts. It will shut down the whole circuit if it's big enough, right?
It,
It ramps it down or it shuts it off.
it ramps it down.
It doesn't ever shut it off?
It goes, there's two things in there. One, the bubble detector, it'll ramp it down. The other thing we have is the limit that it doesn't go under the 100, the 0.1 of flow.
Yeah.
So it will drop it all the way down.
And shut it down at that point in time. So that the theory is if it slows it down, that somebody will jump up, and this is why there always needs to be an echo specialist at bedside, is because if the bubble detector starts alarming and your flow is ramped down, you want somebody right there who knows immediately what that is and can jump up. And actually, I didn't put it in the right place, because where it typically is before the bridge, so that then you have a chance of sucking whatever is in here out of your circuit before it goes to your patient.
Would you clamp open the bridge and then suck it out, or?
Yeah, it depends on where it is, but yeah, you could do that, or you don't, or.
We don't open the bridge.
Okay.
Because for one, if while they troubleshoot it, If they were to open the bridge and override it and try to get it to flow again, then you send air to both sides of your circuit. So if we can isolate it and get it out one side without having to debubble two sides, then that's what we're gonna do. But we will use the stopcock on the bridge, but not necessarily flow through it.
Yeah, that's what I was gonna say, was gonna clarify that you don't open both sides of the bridge. You can see that there's a stopcock built in here. So you open up the arterial sides, so that then you can draw off on the arterial side, but don't open it to the venous, so it's not shooting, as she's saying.
So that detects both air embolus and thrombus, both of them?
No, not the bubble detector.
Oh, the bubble detector, you're right, it's just bubbles, just air bubbles. See, this is why Kim's here.
So there's not a large embolus detector. Okay.
It doesn't, I mean, there's not, most of the emboli that we, the thrombus that we have within our circuit comes on the, so it's tricky, because when people talk about the venous limbs of the circuit, there are two ways that people talk about the venous limb. One way that people mean when they're saying the venous limb is they mean pre-cone, and the other thing they mean is pre-oxygenator. So when people are talking about venous limb, you may have to clarify with them which it is that they're actually talking about. In this case, for me, I mean anywhere on the entire venous pre-oxygenator side of the circuit is where we see thrombus. For some reason, we see a good amount of thrombus that layers out here, and it doesn't matter whether it's high or low in the circuit, it layers out here, and it's probably coming from this adapter here, and it just streams along, and it stresses everybody else because it's pointing right at the cone, and if it breaks free, and then you can shut down your cone, and then we get a lot of thrombus in here because we have all of these stopcocks, and those go to your oxygenator. And most of the time, they don't stop it, they just slowly cause it to decrease functionality. The other thing I realized I didn't talk to you guys about was de-airing, so that if you get air within the venous side of the circuit, it's gonna go to your oxygenator, and one of the nice things about the Quadrox is it's very easy to de-air. The port you see up here, the cap you see here, has a valve on it, and if you open it, so if blood is flowing in and it has air within it, it's gonna layer to the top right. So if you take this cap off and it's just a small amount of air, it'll come out. If you have a large amount of air, so it's impeding flow through here, then the ECMO specialist may have to work harder to push the air through and have some technique